program soon, so may I invite you to take your seats, fill up the crumbs, and turn your mobile phones and other electronic devices to silent. Welcome to the inaugural SSHSPH School of Public Health Thought Leadership Series. Today's lecture is Personalized Medicine Promises or Perils, delivered by Professor Harvey Fineberg, President of the Institute of Medicine, USA. Today we will be using Pigeonhole Live for our Q&A sessions. If you have a smartphone, a tablet, or a laptop computer, you can log on to phlive.at. This is the address. And once you've logged into this address, enter in the code for today's event, which is SPH. Once you have entered the code and pressed go, you'll be brought to the main page where you can choose between the feedback form and the Q&A session for this talk. And once you're in the Q&A session for this talk, it will enable you to post new questions, or if you see a question that you'd like answered, if you'd like to vote for it, it will allow you to vote for the question that you prefer as well. Questions with greater numbers of votes will have a greater likelihood of being answered by Professor Fineberg. Alternatively, if you're unable to make use of Pigeonhole Live, you may raise your hand and somebody will show up with a pen and paper for you, or otherwise you may just make use of the standing mics that are available throughout the auditorium. All right, now I invite the Dean of the SSHSPH School of Public Health, Professor Chia Singh, to introduce our speaker.
Good afternoon, everyone, and welcome to this Public Health Thought Leadership Series. We hope that through this Public Health Thought Leadership Series to be able to assist us in crystallizing issues that would affect the health of the population. As you know, in clinical medicine, the main focus is on the patient, on the individual. But in public health, the focus is slightly different. The starting point for public health is the population, and in how to keep the population healthy and how to prevent disease and complications at a large group population level. And we hope that this series will be able to help us to crystallize some of our thinking around various topics. So you may be surprised that for today we have chosen a rather clinical sounding topic, personalized medicine. Personalized medicine, most of us have heard of the term personalized medicine in its various forms. The last 10 years, when we put up our research grants, we'll make sure that it's heavily peppered with the word personalized medicine. If we write our research paper, we will somehow say that this will translate into personalized medicine. And for those of you who are in the know, this coming October, November, when the International Advisory Council for Biomedical Sciences Initiative meets in Singapore, one of the areas that we'll try to introduce is now stratified medicine. So from personalized medicine to stratified medicine. And if you look at the web, something that's even more catchy and sexy now is precision medicine. Right? So you have personalized medicine, stratified medicine, precision medicine. What does it all mean? Do they mean the same thing? And what does it mean for, of course, the clinicians, for the patients, but in particular, what does it mean also for public health? What does it mean for the population? So we're very glad today that we have Professor Harvey Fineberg. president of the Institute of Medicine, to help us to think through some of these issues, to help us to crystallize the idea of what's the interface between personalized medicine and public health. Harvey was formerly the Dean of the Harvard School of Public Health, and then as well as the Provost of Harvard University. And I have the privilege of engaging him for the last couple of days. And one thing that I must say is that firstly, he's a very sharp thinker. Secondly, he's a very clear communicator. And the discussions that he brings to the table are always very thought-provoking. So I'm sure we'll be in for a treat today. And so join me to welcome Professor Harvey V.
Thank you very, very much for that very generous introduction. And even in the introduction, as you can see, we have gone through 3 generations of terminology, from personalized to stratified to precision. And what is this all about anyway, and what does it matter? Is it real? Is it here? Is it in the future? Does it make a difference for patients and their families? Will it make a difference for public health? So these are the questions that I want to discuss with you today. Pictured here is the cover of Nature when the first report a decade ago of the human genome came forward. Science published, Nature published, all the groups were working, and they laid out for the first time the sequence of all the base pairs in the DNA of the human genome. And it was a milestone in biology. And in a way, it triggered the discussion, the focus, the consideration that had been building over a period of years, even several decades, but now crystallized and accelerated around this question of, could we learn more from that genome that would enable us to understand more specifically in each individual their propensity to illness and which disease, their responsiveness to therapy and in what way, their prognosis over time. Now, as I ask these questions, it must be evident that none of those is a new question, certainly not for clinical medicine. In fact, haven't we always been striving to proceed with individualizing the, I'm glad we're starting later, to individualize the care and understanding of our individual patient? Haven't we always striven to make a specific diagnosis and to match therapy to the needs of the individual? And I want to come back to explore with you in the course of this discussion what, if anything, is potentially different today in that quest for individualization. But most importantly for our purposes, I also want to introduce and raise some questions that relate to the larger implications for society and especially for public health that may grow out of this revolution toward increasing precision. But let me begin just to identify some of the array of terminology to try to clarify what I mean when I use these constructs. When I talk about precision medicine, I mean the increasingly specific targeting of interventions to the conditions of the individual patient. Interventions can be very broadly construed as treatments or therapies or preventives. They may be individual, one at a time, or they may be also mounted to large numbers at the same time. In the past, some of the terminology which has been used may carry different connotations. Personalized might imply that it's unique to the individual, but increasing precision might apply to a larger number of people at the same time. Stratified might imply that there's a hierarchy of superior and inferior. And so this does not necessarily mean better or worse in the targeting of individuals and even of groups, simply different. Some years ago, Ilyas Zerhouni, when he was the director of the National Institutes of Health, and Lee Hood, who was a pioneer in genetics based at the University of Washington, popularized a concept they called 4P medicine. And their 4P medicine included personalized, but it also included preventive, predictive, and participatory. So they had a concept in mind of a new way of engaging in the health enterprise to improve the life chances of patients and to cure disease that would have these 4 attributes. It would be personal, it would be predictive, it would be preventive, and it would be participatory. Others have added other terminology. P seems to be a favorite first letter, so some people also talk about preemptive medicine, interventions which are designed not simply to predict and not simply to prevent in general, but to literally eradicate the risk, to preempt the development of disease. And so all of these concepts are really oriented around the same idea that increasing knowledge about human biology and the human condition will enable increasingly specific choices to be made for each individual at each point in time in terms of their health and their health care. So this is the concept that we're going to be considering today. The modern building blocks for what I prefer to call precision medicine include a number of elements, some of which are biological and some of which are social. So these include the increasing specific knowledge about genomics and epigenetics, proteomics, metabolomics, microbiomics, the increasing understanding of the human microbial interaction. Do you realize that at this moment, for each of us in this room, there are more microbial cells inside our bodies, mainly in our gut, than there are human beings on the face of the planet, in each one of us. So we coexist already with a massive microbiome that inhabits us and in ways that we serve its needs as much as it serves our needs. Web-based knowledge has radically altered accessibility to all levels of information that may bear on health. It has many implications, including the fact that an abundance of information does not necessarily translate into knowledge. And knowledge alone does not necessarily equate with the wisdom to make good choices. But we have a superabundance of data available on the web. And we have increasing capacities because of systems of data management and use of large databases to assemble and have accessible, not just to the experts, but to anyone, increasing amounts of relevant knowledge. Mobile technology. Some of you may have the irresistible urge now to take out your mobile phones. I had this similar urge once in a lecture. I felt like I knew exactly what they were going to say. It was really kind of boring, and then I realized I was the one doing the talking. So resist the impulse for the moment. But mobile technology is ubiquitous, and not just in advanced, wealthy countries. It's everywhere in the world, and it transforms the ability to monitor and track. Already there are apps that will enable you to monitor at home highly personalized, individualized aspects of your care. It won't be very long before self-monitoring, not just with apps on phones, but the clothes we wear, pills we'll ingest, items that will be attached, will enable a degree of personalized monitoring that was simply unimaginable even just a few years ago. So mobile technology is going to make a huge difference. Another very important development is in decision support. I don't know if you're familiar with the computer named Watson. Does that name mean anything to you? I don't know if they show on television in Singapore, or if any of you watch these things, the game show Jeopardy. Do you have something here called Jeopardy at all? Are you familiar with it? Well, there was, Jeopardy is a game where any topic may be the subject, and any answer may be given, and the object is for the contestant to be the first one of three to pose the right question for that answer. So the answer might be Singapore, and the question might be, what's the best place in the world to live? Usually, there are very specific questions that are required to make the correct answer. And there are some people who are incredibly astute at this game, and they win repeatedly. So there was one individual named Ken Jennings, who was not just a 5-time champion, but a 5-time champion among champions. And there was practically no question they could ask on any topic, whether it was popular singers or medieval history, that he couldn't answer faster than anyone else. So the wizards of IBM developed programs and computer technology that they named Watson, because Watson was the name of the founder of IBM. And this computer was a self-learning computer that was enabled with masses of information and algorithms of selection to interpret the questions just as if it were a human auditor, no special inputs, it just heard the same language that everyone else did. And then the algorithms enabled it to put forward answers. So not only now are computers superior to the best chess players in the world, but Watson defeated Ken Jennings in Jeopardy. Now, I ask you, if there's a computer that can answer correctly, giving the right question to any fact that could be thrown to it, do you doubt for a moment that that same technology cannot be used for better diagnosis than, if not most physicians, at least many physicians, and possibly any physician on the really hard cases? So decision support, which has been very primitive in the past, enabling the doctors to utilize technology to aid in the diagnosis, treatment, management of the patient, decision support is going to undergo a dramatic revolution in the next decade. And I ask you this, if Watson could help any doctor make a diagnosis, why can't you access Watson from home without going to the doctor? So the opportunities for mischief as well as for goodness are coming in terms of decision support. And as a backdrop against all of this is the social movement in many countries of the world which give patients a greater sense of authority over their own care. Responsibility to be a partner and to take responsibility and control for the choices that are made in their behalf, because it's their body and they have that right. So all of these forces are the building blocks that are creating the threshold of a new era of precision medicine that can be very different in a lot of practical ways than traditionally practiced modern medicine. So where is this today? Actually, if you ask, well, how many examples can you cite of real cases of instances where this kind of detailed, precise, personalized knowledge has made a difference? Well, it makes a lot of difference for breast cancer today for many patients in terms of delineation about whether they have a tumor which expresses HER2 and treatment choices that can be made as a result. There are some isolated individual cases. I can tell you about the case of twins in America that had what's called DOPA-deficient dystonia. It's a very rare condition, but literally analysis of their genome was what produced the insight that enabled them to be treated with serotonin, which corrects the malady which is otherwise fatal. We're entering again on a threshold of a very new era of treatment of bacterial diseases. You know the world is running out of effective antimicrobials. The bacteria are evolving and adapting faster than we are creating newly effective antimicrobials in the conventional mode of antimicrobials. This is a huge problem, and we are making it a lot worse because we do many things that foster the selection of resistant bacteria. We overuse antimicrobials. We overprescribe them. People throw them away when they think they're better. They throw them into the sewage, which creates resistant organisms in the sewage. You have treatment in many countries where antimicrobials are used much, much more in the treatment of animals than for humans, and not to treat disease. They're used as growth enhancers to enable the chickens and the hogs to grow faster and therefore be more profitable. So we do a lot of things to make our struggle to create antimicrobials harder. We need new strategies. And we're on the threshold of new strategies by virtue of deeper biological understanding of the vulnerabilities of microorganisms, both bacteria and viruses. There's also what some refer to as low resolution precision, in which, for example, optimal treatments for certain conditions depend on periodicity in one's life, menstrual cycle for women, and other ways in which the biological condition predisposes to more or less favorable treatment at particular times. And then there are certain drugs which genetically we know vary enormously in the metabolism of the body, so that the optimal dosage is very different for one person than another. Coumadin, blood thinner, is a very prominent example in which some people are very resistant because they metabolize rapidly, and other people are very sensitive because they're slow metabolizers. And in order to differentiate the two, in order to give the proper dosage, is a very important challenge, and enabled to a degree today through precision medicine. But the honest assessment is that most of the promised effects of the genomic revolution have yet to be affected in real terms for the care of individual patients or for the management of population and public health interventions. This is still in the future, but it's a future that seems inevitable. What's not clear is what that time constant will be for its inevitability. Now, what are some of the implications of these developments for academic education and for society, public health, as well as medicine? First, the ability to manage data and to convert data to information, to knowledge, to choice and informed judgment. All of this is going to have a higher and higher premium across the health professions as across many dimensions of society. And in order to do this intelligently, and in order to make sense of all of these data, we need more than just data experts involved. We need experts in statistics, we need experts in computation, but we need substance experts in the varieties of clinical conditions and social conditions, which are the subject of these data analyses. So one implication is the heightened value of integrated, interdisciplinary, and transdisciplinary research and education. Second, there will be an altered relationship, I think, of doctors to patients. All of us are familiar with the traditional authoritative physician. That model is very familiar. You go to your doctor, the doctor says, this is what you do. If you don't like it, find another doctor. Have you ever encountered a doctor like that? More or less. At the other extreme, we have what I call the postmodern doctor. This is the one who says to you, well, you have this problem and that problem. There's a lot of literature about it. It's complicated. It's not clear what to do. Here's 100 articles. Take them home, sort them out. When you decide what to do, let me know and we'll proceed. So in between somewhere is the partnership model, in which there's a genuine back and forth exchange. And the respect of the doctor's knowledge and the patient's preferences both play a part in the decision making. So precision medicine and the availability of more and more information is going to greatly empower the patient for their side of this relationship. And it's not a simple choice for clinicians because sometimes patients actually simply require authoritative direction and guidance to say, this is what you should do, and the doctor takes responsibility. It's not the patient or the family. But sometimes the patient really wants to be in charge. And so the new relationship is not that the doctor adopts a uniform attitude, always authoritative, always postmodern, always a partner. But the doctor is attuned to the needs of each individual patient and plays the role that that patient needs at that time. Precision medicine is going to empower the patient to be more likely able to play their role. Another reality, because of the dissemination of information, is the decentralization of research. And the same reason we need teams for understanding is the same reason we're going to need greater teamwork in conduct of research. But patients increasingly are going to be able to define and decide that they're appropriate and suitable for this or that intervention or clinical trial by simply referring to the web and maybe consulting with a Watson-like computer. So decentralization of both research and team-based research is one of the implications. All of the need to work together means that we're going to have to be training more people in concert. Public health, medicine, nursing, pharmacy, there will have to be more opportunity for interaction to understand the contributions and the skills that each brings to the specific care of each patient. Very importantly, I believe what precision medicine opens up is a new era of thinking about the taxonomy of disease. We are still grounded in our diagnostic categories in 19th century concepts of pathology and histology. We're still basically defining disease according to the appearance of tissue and organs that are diseased. Increasingly, as molecular markers and genetic differences will differentiate the appropriate intervention for each particular patient, the old diagnostic categories will no longer be as relevant or as useful. If you think about it conceptually, all of our diagnostic classifications are simply intermediaries between the conditions, the symptoms and signs that the patient begins with and the treatment or the preventative, which is ideal for that patient. Everything in between is simply a signpost, a guide to take us from the start to the end. And what precision medicine potentially offers is a wholly different level and type of classification. Maybe the appearance of the cells will no longer be as important as whether a particular genetic marker appears within or on the surface of that cell. And that may be true or not true of cells that are today thought of as very different diseases, but in fact share a particular susceptibility to treatment that today we cannot discern, but precision medicine might allow us to recognize. And so thinking about the future taxonomy of disease will be thoroughly revisited as we have more and more precise molecular ways to understand the function of illness and its expression physiologically and in cells. Another implication of the data emergence is the potential for a very different construct as the usual way of understanding normal and abnormal results. For most tests that we do today, whether we're looking at diagnosis for clinical treatment or classification for public health interventions and trials, mostly we define normal according to a population distribution of current results amongst people not known to be ill, and we define boundaries, typically 95% interval of the patients or the individuals in the population who have this particular measure, and we define the normal as that cross-section of the population bounded in the upper and lower bound. So any metabolite or electrolyte or physiologic measure, typically that's how we define normal. Your blood pressure, your cholesterol, your sodium, your potassium, that's the usual way. What precision medicine and increasingly individualized measurement opens the possibility that more and more understanding of your normal will be not in terms of how you compare to a cross-section of others in the population, but how your present result compares to the trajectory and history of previous results in you and people like you. So now, normal might be defined very differently in terms of your own history. So if you started 2 years ago at the low normal range, let's say for thyroid function, and now you're at the medium to high normal range, you're still in the conventional way thought of normal, but in the new way, you might be detected as having an abnormal trajectory. And that opens up all new ways of thinking about the potential for intervention, maybe even preemption, and also defining in new ways how we sort populations for public health management and public health understanding. A very big challenge in epidemiology is to understand all of the different levels of causation in their relationship of one to the other. Many studies demonstrate that socioeconomic factors strongly relate to the likelihood of survival or mortality. Many studies have replicated this and similar findings. How exactly does a change in socioeconomic status, or as some studies have looked at, changes in even the equity within a community, affect the life chances of individuals? How does that work? And if you think about layers of causation in epidemiologic terms, from genetics to metabolic measures, to physiologic measures, to behavioral measures, to environmental measures, to socioeconomic measures, how do they all map one onto the other to ultimately create the conditions of good or bad health? This is a huge challenge. And it's a challenge that I equate, in my mind, to the grand unified theory of forces in particle physics, trying to bring together all the different forces. Because in epidemiology, we have an analogous challenge of mapping precisely all of these layers of causation. Precision medicine opens up new avenues of possibility and capacity for data analysis, new opportunities to make this map a greater reality. And that's going to be one of the great opportunities and challenges for public health growing out of precision medicine. But I think there's even a more profound impact for public health. Most of our interventions in public health are defined in terms of shifting the norm of a population to a healthier level. We tend to advance interventions for a population as a whole. So we try to lower the average blood pressure and shift the curve of blood pressures to a healthier level for population. We try to reduce salt intake to what we believe is a healthier level on average in the population. Now, it's entirely possible that different individuals, and there are some data to suggest, in fact, different individuals are highly differentially sensitive to the effects of salt on blood pressure. What if we identified the genomic predisposition to resistance to the ill effects of tobacco smoke, if such existed? Would public health be able to absorb the possibility that tobacco smoke may not be harmful for 10% of the population? I think that would be a hard pill for us in public health to swallow. Because we know smoking 1 cigarette is more dangerous than smoking 2, and smoking 3 is worse than 2, and smoking 4 is worse than 3, and we know there's a very high risk to use of tobacco, but we all know some ancient smoker who somehow escaped lung disease, heart disease, and all the other ailments that are associated with tobacco. Was that just stochastic, a chance? Or is there something about their predisposition? Or put the other way, suppose we could identify the 10% that are especially vulnerable to the amount of sugar in the diet that most people can just consume without any ill effects. Would that change our strategy? Precision understanding of health and disease in the individual opens up a great challenge for public health in rethinking intervention strategies previously orientated to the entire population and perhaps now more precisely targetable in ways that may even be more acceptable to those who are, in fact, themselves now understood to be more valuable. So these are going to be some of the implications for public health and for medicine and for the development of new therapeutics and drugs, because we have more and more precise targeting of drugs. So drugs that are today oftentimes ineffective in a substantial minority or even a majority of those who receive it, but work in enough of those in the remaining group to be on average worth trying, may be increasingly targetable to that subset that will have effective response to that particular drug. And so it will change the dynamics potentially of drug discovery as well as therapeutic strategies. Very important implication for industry is how this will affect strategies for research as well as business strategies. We just had a case in the United States decided by the Supreme Court of the United States on the patentability of genes. This was a case that was brought against a company that had patented breast cancer 1, BRCA1. They have developed tests and they have marketed for many years these tests based on that patent, which was approved originally. And the Supreme Court in the United States ruled unanimously that you cannot patent a gene. This is based on a long-standing principle for patents that you cannot patent natural phenomena. I don't know if you've ever heard of the Morse code, dits and dashes to convey letters. Well, Samuel Morse in the 1850s in the United States actually tried to patent, in effect, the entire electromagnetic spectrum. And at that point, the Supreme Court said, no, no, no. You can't patent a natural phenomenon. You can patent something you do with the natural phenomenon. So if you have a test that detects that particular gene, you can patent that. But you cannot patent the natural phenomena itself. All of these possibilities raise profound concerns about privacy and the protection of individualized information. And increasingly, more and more information about every one of us is known to others, and actually many of us are voluntarily putting out information. How many of you use something like Facebook? You're putting out information to the public that a generation ago would maybe not have been thought to be for public consumption. I can tell you in the United States, and I would be surprised if it's not true in Singapore, every time I leave a supermarket and use a particular card to pay for those goods, somewhere it's recorded exactly what goods did I buy with that card. And so the companies will know how to target advertising to someone who tends to buy that type of product and not waste their money going after people who don't buy that kind of product. So privacy on matters of health, and especially on vulnerabilities and on our personalized risk, creates another level of concern that has to be taken into account and both protected, but even more, I believe, made secure by virtue of severe punishment for misuse of that information. And that is going to be a very important part of the debate and the policy discussion about the implications of precision medicine. I just would conclude with a single thought. For public health, for individual care, what we're talking about is a potential in the main. It's not here today. But all of these forces are pointed in the same direction. Many of these possibilities will likely become realities, and maybe faster than many of us would anticipate. But I would say that we need to use patience in both terms, of the individuals who are the object of our interest, and in the quality of willingness to take our time and not overpromise. Better for us to underpromise and overdeliver. Thank you all very much.
Thank you, Professor Fineberg. We have questions.
Okay, what we'll do is take the next half an hour or so to perhaps answer some of these questions that have been posed by the audience. And if you have additional thoughts or additional questions, just go ahead and submit them. So since I'm pretty democratic, I hope, we'll start with the one that is most popular. So let me see how this works. So the question here was how to balance public health and personalized medicine. Specifically, an example here is that should we advise health behaviors according to a person's genetic background?
Right now, most of the time, we really don't know enough to differentiate those who are more or less susceptible in the population. The tobacco example was one that I cited while I was speaking. So today, as a real and present and practical decision, choice for public health, we are certainly better serving the needs of the population by targeting the whole population who may be susceptible when we advance our programs. We would, however, even today, target according to particular identifiable attributes, some obvious, such as the difference between the sexes, men and women. You wouldn't target men for certain types of birth control education, and you wouldn't target women for prostate screening and cancer detection. So we already, in a way, do make some obvious divisions. I think the challenge for us as information and knowledge will grow about the precise risk levels, we may all have the equivalent by our personalized analysis of a personal risk profile. And we'll be able to know for us with greater confidence than it's possible today. It's possible only in the most general sense today. What is our susceptibility to development of diabetes, to the development of asthma, to the development of heart disease, to the development of Alzheimer's, to the development of, you name it. And with that information, it might be more motivating for us to take steps that would increase the likelihood of longer times at good health, because we are informed and we know that we have these susceptibilities. So I would divide the answer into two parts. Today, we generally have to target the whole population. But over time, as personalized, individualized, precise risk profiles may be obtainable, it could be more successful to take advantage of that awareness to target more precisely individuals with certain interventions. Even today, if you thought that children were more likely to adopt healthy behavior if it's part of the story of a comic book than if it's a public service announcement from authority, I think we would choose to use the comic book based on what works. So in the same way, over time, as we learn more about individualized risk, and we can test in a comparative way what actually works better at prevention and intervention, I think we can be very pragmatic and choose the way that will work best.
But related to that is this whole notion that in public health we want to target bigger groups, almost like get more the outcome for the buck. With this approach of precision medicine in public health, you tend to actually go against that flow of thinking. How do we then go about training a new generation of people, for example, to think that way, or newer methods of evaluation?
Let's start with first principles that you articulated. Public health is about the health of populations. Right now, most of the time, if we are trying to enhance the health of the whole population, the best strategy is to deploy whole population intervention. As long as that is true for public health, then public health should use whole population intervention. Over time, it's possible that increasingly precise knowledge could show the ways in which more narrowly targeted intervention accumulated over the whole population results in better population health than a strategy which is simply global for the population. So public health, its great strength is that public health is focused on solutions. It's not wedded to a particular strategy, or wedded to a particular technology, or wedded to a particular discipline. Public health is always about solving the problem. And as these technologies come along, if they provide more successful ways to ultimately improve the health of the population, then we in public health have to rethink our approach to intervening in the population.
Let's pick another area that seems to be quite popular here. In terms of the genomic technology to map specific traits for a large number of people in the population, do we have the capacity right now, and would it be ever feasible?
The question is framed in terms of specific traits. If I modify that to simply say the specific genetic sequence, then the answer is yes. What is very unclear, and which is a huge, exciting, important field for statistics, sometimes called genetic statistics or statistical genomics, is the opportunity now to still decipher from the genome the relationship between various patterns of sequence and human traits, which is what the question actually uses. So that is a very early stage, a nascent stage of development. But the cost of sequencing the human genome is plummeting. When the Human Genome Project was carried out over a period of about a decade, the total cost of that project to do the first genome sequence was on the order of 2 to 3 billion US dollars. Now, it's possible to sequence a whole genome for under $10,000. Some volume and devices at a level of 5,000. It's clear to go to 1,000, and maybe even into the hundreds. When it gets into that level of cost, and after all, what did we just hear? Hong Kong last year sent back 6,000 Hong Kong dollars to every citizen over age 18 just because they didn't know what to do with the excess of the monies? Well, if Hong Kong can send $6,000 back, Hong Kong dollars, just for the year to do as you will, for many societies, it will be affordable. It will be affordable to do population-wide genome mapping within 5 to 10 years. And then the question is, what good will it do us? And that is a much harder, longer-term question.
Yeah, so I suppose there's a question here that kind of along that line, that in the meantime, while we are trying to still struggle with the implications of being able to sequence everyone and so forth, there are already many initiatives of, in terms of personalized medicine in very fragmented ways. What's the implication of that in terms of to the healthcare costs, and how should the healthcare community respond to that?
This is a question about policy toward coverage of testing and interventions. And I think every society has to come to grips, if it wants to maintain a practical and affordable health system, what model, what does it use to discipline the choice of interventions? Does it use market-based discipline in which individuals decide, I'm going to get that or get this? Does it use centralized authority to decide what is essential and available to everyone and what is outside of the essential base? But fundamentally, this is no different. This technology is no different than any other new technology on the question of whether it will be part of the usual care or apart from that. And I think that we'll have to apply the same standards, the same questions about what difference it makes and at what cost in order to come to those decisions about genomic and personalized technologies, just as we do with imaging or any other technology.
Yeah, but the difference, I suppose, would be that now there is more influence, for example, from various companies, various interest groups, to a far greater extent, perhaps, than in the past. And in countries or in the communities whereby there is no systematic health technology assessment kind of framework, most of the time it's going to be an issue of just let's follow what US is doing, let's follow what UK is doing, and so forth. So how do we, on the ground, say here in Singapore, struggle with this kind of issues?
I hope that we can have the presence of mind and the discipline to ask the same hard questions, and not just to be dazzled by the newness of this technology, and fundamentally ask, what is it that we can do now with the resources that in every society are limited to some degree or another? What can we do now that will most improve the life chances and health of the population? And if we constantly ask that question and give honest answers to that question, then I think we've done as well as we can to point the way toward the investments and the interventions that make the most difference for health today.
Mark, you have a related question?
Well, not actually, but I thought to just give my comment about something and then at the same time try to see whether or not people agree with me, and then ask whether anybody has a solution. I think that, in my opinion, it seems like the weakest link in all the building blocks that you showed in terms of getting widespread uptake of precision medicine is probably at the patient empowerment, or I think even the community empowerment level. I think for, most of us will know what Angelina Jolie did. Okay, so, some of us will know, okay. But the fact is that we've got mammography, which is, a overcome the existing challenges of getting people to take up these kind of screening and preventive type intervention measures. And I'm just wondering whether the panel here or anybody else in the audience has any thoughts about how to deal with this problem.
Well, I want to say I did not plant this question, but literally in today's release issue of the Journal of the American Medical Association, JAMA, there's a special communication on the paradox of prevention that takes up exactly this set of issues about how can it be that we all know prevention is a good thing, but it's so hard to have it incorporated into our everyday lives and in practice. I think it's I have to say, I think it's an absolutely brilliant article. I wrote it. So you'll forgive the self-aggrandizement. But it's my effort, in a way, to come to grips with this problem. And it's obviously not an easy question because we would have solved it. But I would love to hear, like you, what others also think. You can read what I think, but I would love to hear what others think about this difficult and really seemingly intractable challenge for us. Precision medicine, you could argue, will not change human nature.
Anyone care to comment? John?
Harvey and Mark, I think that I think is probably going to be the biggest conundrum. I think there are going to be two conundrums about personalized precision medicine. I think one is the ultimate recipient is the patient themselves, who may or may not want that information. And even if they have that information, may or may not want to act on what that information tells them. We know, for instance, that the compliance with life-saving oral medication, and the example that's often been quoted is tamoxifen for breast cancer, which is probably one of the least so-called toxic drugs. But the compliance rates in the United States and in Canada, and probably the rest of the world, is about 60% after 5 years. So 40% of women do not take a life-saving drug after 5 years for a multitude of reasons. So that's one issue, and the same these figures are probably worse for men, but the study is probably just not being done in men. And then the second issue is the accuracy of the test. You very elegantly pointed out at the beginning all the omics. And right now what's coming out is the genomics. But we still haven't factored in the impact of the metabolomics on the genomics and the impact of the epigenetics on the genomics. So even though we get a signal, how accurate is that signal going to be? You mentioned HER2 in breast cancer, and it's now becoming a bigger, a problem that people are wrestling with, whereby the primary tumor may be HER2 negative, but in the course of the disease, the metastasis in up to 20% of patients may become HER2 positive. And so conditions can evolve. So I think that it's going to be not only an issue of the validity of the test, but also the time point at which the test was done, because situations evolve. So I think that the fascinating thing about medicine is that it's constantly evolving. We're going to see new normals roll out. But I think what we do need to do in parallel is that we do need to really encourage society to really debate what are these new normals going to imply. Because quite clearly, the big burden of chronic disease, unfortunately, is unfairly shared by the lower socioeconomic class. And how do you impact on a group of a population which is at much higher risk with technology that's still not fully worked out? So, I think that we'll invite you here, Harvey, every year, and you can share with us your thoughts, or you can write an editorial in JAMA as time goes on. Thanks very much.
Excellent comment. I think I agree exactly with your points. All of this should not obscure that we today know a vast amount of relatively straightforward things that, if applied by the whole population, would dramatically shift the risk factors of that population. So diet and tobacco, activity, exercise, smoking, excess alcohol, it's a handful. And if we were able, with the existing knowledge of epidemiology and risk, never mind all of this additional precision, simply to act on what we know, it would transform health chances. And so another way to think of this is, even as we in public health may be anticipating some of this revolution and some of these changes, it should not deflect our attention to those things we know could work today, and do our level best to ensure that it becomes the easy, natural, cheap, and culturally accepted way for people to live. That's what will make more of a difference for public health right now than any more precision in our genomic understanding.
I'll probably expand. I mean, I think that probably all the best examples so far of precision medicine have actually been, I would say, in the field of oncology. And one big, I guess, paradox is the whole warfarin story. We do know that there are molecular tests that can tell whether you need a small dose or a big dose of warfarin. But physician uptake has been so poor. And that is a challenge. Is it because they can't interpret the test? Is it because the turnaround time is too long? Is it because they feel that they know better than the test? But it's really unusual that the biggest inroad in precision medicine has been oncology, but it hasn't been able to break out into other diseases.
Well, you raise actually a whole additional category of concern about the rapidity of uptake of demonstrably valuable interventions. Consider beta blockers after myocardial infarction. In the United States, it was almost 2 decades before 80% of institutions routinely prescribed life-saving, very simple, very cheap drugs after a heart attack. So there are some attributes of this business of diffusion of practice and speed of uptake that are not obvious. And maybe ultimately what is a stronger solution is, in effect, a substitution of a better technology that doesn't require the action anymore. So you have other blood thinners that work as well or better, and you avoid the problem. You dissolve the problem. Yeah, it's a little bit like putting the airbags in the cars instead of relying only on seat belts. So you still add protection even if you don't get the action from the individual.
Well, there are several people who wants to get to know you better. Are you for or against personalized medicine?
It reminds me of the question that was asked to Bernard Lown, who was a very distinguished cardiologist and the founder of something called the International Physicians for the Prevention of Nuclear War, with a Russian colleague named Chasov. And the two of them were representatives of this organization when they received the Nobel Peace Prize in 1986. And Lown was asked, are you an optimist or a pessimist? And he said, I'm a pessimist about the past. Because there's nothing I can do to change it. But I am an optimist about the future because that is ours to shape. And I feel about personalized medicine it was good in the past. Maybe we can make it even better in the future.
Well, another question here is in terms of the ethical consideration in personalized medicine, and I think especially when applied to population level.
Ethics is an ambiguous term in this question. I think that the first point of ethics in application of any intervention, public health or individual, has to be an informed and knowing decision on the part of the individual to participate. And so I think the first requirement for ethical practice of applying of knowledge, and John actually raised this question, people might not want to know in the first instance. And we often talk about a right to know. Does a patient have a right, or an individual have a right to not know? Do I have a right to be oblivious? A veil of ignorance that I want to wear between me and this information? Or do I have an obligation to know? Now, you might say, well, if we're talking about a sexually transmitted disease, maybe you don't have the right to a veil of ignorance because you are putting others at risk. But the ethics of personalized information, which has no bearing on others, might be your choice in the first instance, even to know, much less to act on. And the second aspect after knowing is taking action, again, based on informed choice, knowing the consequences and the risks as well as the potential benefits. These are all part of the calculation that every individual would be entitled to. And so this is not in character different than the ethical requirements of any intervention in public health or in individual clinical practice. The difference is only that personalized individual information at this level of genomics is somehow more intrusive. It feels more core, more the essence of ourselves. And so we have to treat it with an added measure of respect and add this opportunity and understanding of the rights of control over their information by each of us as an individual.
Perhaps I think we have time for one last question, and I'll take the one that has the highest vote. And it is basically to do with the amount of information and how do we communicate this information to the public and to patients in general.
You know, this is a question about the difference between having information available and having good information available. Information that is reliable and information which is misleading. And one of the dangers of a plethora of information, data, and stories available to anyone electronically is that very much of it is simply misguided or incorrect. And so what I think the information revolution does is put an added premium on the willingness and ability of those with knowledge, such as at the university, to be able to share their perspectives and their understanding about many of these issues with the public. So there are at least opportunities to get more reliable and more informed data and information for the public. We, I believe, have the same opportunity to make our information as appealing and attractive and usable and easily digested as anyone whose purpose or inadvertently is misleading the public. And I think part of the burden and responsibility of those who care about the public's health is to do all we can to put information that's not only correct, but also usable and accessible, understandable. And that's going to be even more important as precision medicine produces a higher order of available information.
Okay, I hope you have all enjoyed this particular session. And it now leaves me to thank Professor Fineberg for sharing with us his thoughts and helping us to crystallize some of these issues. Thank you, Harvey. And we have a small token of appreciation for Harvey to help you to remember this session.
Thank you, ladies.